Hello, dear friends. Hello. Hi, Michael. How are you?
Hi, how are you, Jaime?
Fine, thank you. Well, how's the weather in New York?
Fantastic. You should be here.
Well, it's in Mexico City. It's 22 degrees Celsius. We're broadcasting live from Mexico City. And let me share with you, Michael, the numbers of our last two programs. The both combined we have reached 33,492 people. We've had 11,101 interactions. People saw it live 12,600 times. It was shared 220 times. 2,097 people have commented the broadcast. We had over 1,000 likes. And on YouTube, which is the English version live, because Facebook is with the Spanish translation, we had 1,129 people that already saw both programs. How's that?
Jaime, I didn't know we had that many friends.
Yeah. Well, I don't know if they're all our friends, but I think they're all enjoying this new way of communicate dentistry, don't you think?
I think it's a fantastic way, not only to enjoy what we are doing right now, but also to figure out what we're going to enjoy in the future. So the opportunity to be a part of this endeavor that you and Colgate are putting, and Mexican Dental Association putting together, I really appreciate it. Thank you.
Yes, it's a great opportunity to thank the people from ID Academia and Colgate Palmolive Mexico, which have sponsored this three-part forum. The first part was in full Spanish with translation into English. Last week we had the English version translated into Spanish, as we are going to do this today. And it's also a very good moment to tell everybody that everybody who appears in this program, including Michael and myself, are doing this pro bono. We don't get any payment to be here. It's just for the fun, and also to communicate important things that happen in the dental life worldwide, because if you go into Facebook, you can see comments from people from all over the world. This is not only happening in Mexico or in New York. And before we go and present our guest, I think it's a good time to remember that movie. Remember, Michael?
I'm young. Jaime, you asked me for it before. I was too young. I was not even born when that movie was broadcasted.
Yeah, well, you were very young, but there was a very famous movie in the marathon with Dustin Hoffman and Sir Laurence Olivier, and where he is trying to get some information out of poor Dustin Hoffman, who doesn't know anything, and he's putting eugenol. He creates pain cavities and then creates eugenol. And he didn't use gloves, he didn't use masks, but he wanted to know if it's safe. So of course, nowadays, safe dentistry has to include a lot of PPE, including masks, including a lot of things. But today we have a great program. But before we tell everybody in the audience and present our special guest this morning, evening, or night, depends on where you're watching, we're going to have a short video from from the forum sponsor Colgate Palmolive Mexico. Please go ahead.
OrtoGuard es una línea completa especializada para quienes usan aparatos de ortodoncia. Cuenta con 3 productos de uso diario que ayudan a prevenir las lesiones de mancha blanca en los dientes. El enjuague bucal especializado Colgate OrtoGuard, con una fórmula revolucionaria en el segmento de los enjuagues bucales, le proporciona a los consumidores una efectividad terapéutica en el tratamiento ortodóntico y en pacientes de alto riesgo de caries. Llegamos a los espacios irregulares generados por la adhesión de la resina y el bracket, previniendo la desmineralización del esmalte hasta un 58%. Libre de alcohol, sabor agradable y de uso diario en personas de 6 años en adelante. El nuevo gel dental especializado Colgate OrtoGuard, con 5,000 partes por millón de fluoruro de sodio, ideal para personas en tratamiento de ortodoncia y o con alto riesgo de caries. Revierte 3 veces más las lesiones de caries inicial y proporciona hasta 40% mayor reducción de caries contra una crema dental regular con fluoruro. Es seguro y se recomienda usarlo diariamente, una vez al día durante el tratamiento ortodóntico, indicado para personas de 6 años en adelante. Durante el tratamiento de ortodoncia, los cuidados de salud bucal exigen mayor atención. Los brackets y alambres ortodónticos pueden impedir una buena higiene bucal. Por eso Colgate ha creado el cepillo dental especializado Colgate OrthoGuard, con cerdas multinivel indicado para quienes usan aparatos ortodónticos. Gracias a su forma en U, cubre toda la superficie del bracket, mejorando el efecto de limpieza en la encía, dientes, alambres y brackets. Las cerdas externas en forma de espiral eliminan la placa dental en la línea de la encía, proporcionando así una mejor sensación de limpieza en los tejidos bucales. Y a su vez, las cerdas internas auxilian en la limpieza alrededor de los brackets y alambres ortodónticos. Sus puntas de 0.01 milímetros pueden limpiar pequeños espacios, proporcionando una mejor limpieza de la superficie de los brackets y alambre. Colgate, siempre a la vanguardia del cuidado bucal, presentó Colgate Guard, la ciencia detrás de tu sonrisa.
Well, here we are. And today I'm very pleased to present you two very famous and good speakers, friends from many Mexicans who are watching us. It's Dr. Yasmi Cristal in New York City. Hello, Yasmi, how are you?
Very well, thank you. From Soho, New York. Hi.
And also coast to coast, from the other side of the United States in the San Francisco Bay, Dr. John Featherstone. How are you, John?
Very good, thank you.
Thank you both for being here. Michael, could you please introduce our first speaker of this program?
With pleasure. So thank you, Yasmi, to allow us to listen to what you have to say and your insights and your experience. Just to give a little bit of an introduction who you are, for those who don't know you. I don't know if there's anyone who don't, but for those who don't know you. Yasmi is a clinical professor at New York University College of Dentistry. She's an examiner at American Board of Pediatric Dentistry. She's on the medical staff at the Robert Wood Johnson Foundation, and she's the president of the Pediatric Oral Health Research Group at IDR. But very importantly, and specifically for what we're talking about today, for the past 25 years, she has been a practicing pediatric dentist, having her own practice. And as you will see, it's pretty amazing that she started when she was only 10 years old. But with that experience, I hope she will be able to share with us today. We're going to learn quite a lot. So thank you, Yasmin.
Thank you, Michael. So if we can go on to the next slide, please. Thank you from Soho, New York City. Thank you, Jaime and Michael, for the invitation to share my work and my views. And thank you to all present and future viewers, especially my amigos Latinoamericanos, for joining us today. I'd like to stress that I have no conflicts of interest to disclose, but in this presentation, I will mention the off-label use of FDA-approved devices, namely SDF and fluoride varnish. Next slide. So I like to start by stating the problem. And I have been working as a pediatric dentist for a couple of decades more. And the pendulum usually goes back and forth between blaming it all in whether it's all about sugar or is it all about the microbiome? Is it an infectious disease? Is it non-transmissible? I get to review a lot of articles for different journals, and lately I've been getting all of these that the latest one is that dental caries is a behavioral disease. It makes me laugh a little bit because I think like, behavioral like kleptomania? The truth of the matter is that all of us who have been in this field for a very long time know that it is truly a multifactorial disease. And that really means that everything matters. Can we see that next slide, please? So my problem is dental caries in young children. If you look at this picture, the rapid progression is incredible on young children. This little guy is 18 months old, and he already requires several extractions that will affect his life for the worse, sadly, for many years. Things would have been very different if I had seen this child 6 months ago. So number one, I cannot stress enough how important it is to see high-risk children as early as possible, ideally when the first tooth grows into their mouth. But if we look at this child and we see that even if he didn't require extractions yet, Traditional restorative treatment involves the use of local anesthesia to remove decay, and that requires significant cooperation from this child. And in my setting in the US, once the child is 2 years old and at least 10 kilos, I can resort to the use of either nitrous, minimal oral sedation, or general anesthesia. But my greatest clinical problem are these very young children who I can't sedate or I can take to the OR, and I have to find other alternatives to help them. Fortunately, in recent years, there have been a couple of scientific advances that give me more options to help these children. Next slide. The very first of these important advances has to do with caries removal. We know that if we do complete caries removal, it is very easy to expose the pulp, especially in primary teeth, and then you're required to do additional pulp treatment. Now we know that the self-healing capacity of the pulp is incredible if we take away the cause of insult. And it is now universally accepted that not all dentin has to be removed. Some clinicians, many clinicians are still stuck on feel the drill, like you see on my picture, to be confident that they are removing the insult. But I want to stress today that the insult is not the dentin, infected, affected dentin. The insult is the carcinogenic bacteria in the plaque that covers the lesion. So whether you like high speed, gentle low speed bursts, a fancy CO2 laser like I like, or just hand instrumentation, teeth with minimal or even no caries removal have similar chances of success than those where all caries was removed. And this is supported by many systematic reviews. So lately, in the AAPD vital pulp therapy guideline that we published in 2017, our work group stated that IPT and pulpotomies have similar rates of success, but IPT presents the added benefit of using a more biological approach. Next slide. So the second advance has to do with new materials. In the AAPD guideline that I mentioned, one of the clear messages is that the choice of material used does not, the material used for either indirect pulp therapy or for pulpotomy does not influence its success. That means that clinicians can choose what they prefer. For IPT, these days with fluoride-releasing glass ionomer materials, which are, they are not, nothing has proved that they are better than some of the old materials, but with their fluoride-releasing properties, not only do we gently promote the position of secondary dentin with a material that is more similar to dentin, but with the improved modified glass ionomers, we can actually be using them as our restoration, which is the case with IRT, ITR, which I will be talking more in the future, in the next slides. Next slide, please. So the important fact is to think ahead. What is it that we need to achieve, right? And when is it possible to accomplish what we need to do, because facial circumstances, their behavior, as I mentioned with my little guys, or their medical status. We may have patients that even if they are older, we cannot use a local anesthetic, or they cannot sit in the chair for a very long time. And then on top of that, whether it's possible to accomplish what we need to do in our forced circumstances, like the setting that we have right now, where we may have the need to reduce the production of aerosols. What I like to stress to my residents in the clinic is that you don't need to remove caries deep into the dentin, as we see in this slide. It is not ideal to leave unsupported enamel that could collapse and leave an open margin, regardless of the material that we're using. But it is also, easier to think of what is it want to accomplish, so then we can plan accordingly. Next slide. How about no caries removal, right? Because we've been teaching incomplete caries removal in our clinic for a couple of decades, and everybody seems to be comfortable with. The part where I think that people start getting a little too itchy is when we talk about no caries removal. And for this, I'm specifically talking about two techniques: silver diamine fluoride, SDF, and Hall technique. Both of them talk about using no anesthesia and no caries removal. With SDF, we are specifically talking about using the application of it as a caries arresting agent. With the Hall technique, we are cementing with glass ionomer a preformed metal crown with no preparation either. So it is no caries removal, no local anesthesia, and no preparation. Next slide, please. So when we have a clinical situation and we need to make a decision based on all of the patient and family circumstances, and we're thinking, can I do something, arrest the decay in this tooth? Am I going to use SDF? Should I use intermediate therapeutic restoration or art? Or am I better off putting a stainless steel crown? What we really have to think of, as I'm going to mention in each one of these, is, am I going to be able to keep this clean? Am I going to be able to keep the insulting agent out so things don't get worse for me again? And the bottom line is either you can clean it properly because it's open so much that it can be cleaned, or you have to be able to seal it. The seal is the deal. Next slide, please. So I'm going to talk specifically about silver diamine fluoride, SDF. I don't have time to go into a lot of details. I just want to, I hope that all of you got access to some of the publications. We listed a lot of resources where you can find details to support all of the things that I'm going to mention. But there have been many, many clinical trials, more than a dozen well-conducted clinical trials done on children all over the world, where SDF has shown efficacy to arrest dentinal ciliary lesions in primary teeth. The arrest rates that we expect that are reported in these studies range from 60 to 91%. The average arrest rate is 80%. But as a clinician, the very first question that I asked is like, wow, either 60 to 90% of the patients, that's a huge range. Please tell me more details so I can decide when am I going to be having better chances of success and where am I going to fail. So I can tell you from all of these studies, we have dissected that anterior teeth, maxillary mandibular, have closer arrest to the 90% number. Posterior cavities, large posterior cavities, are closer to the 60% number. Also, cavities in the occlusal surface are not quite as likely to arrest rapidly as buccal and lingual smooth surfaces. And then the crucial thing is presence of plaque. Lesions that have a clear visible plaque index have a lot less chances to arrest. So from here, you start weeding out, okay, if you're confronted with a specific clinical situation, which is going to be your best choice. So SDF seems to show success at the tooth level, but not in all cases. So you have to pick which is the good case. And it is definitely not an option on teeth that are pulpally involved. So if these teeth already have symptoms that make you believe that the tooth may be going into a non-vital situation, it is probably not your best option. Next slide. Rather than doing another systematic review, sadly, there are more systematic reviews on SDF than there are good studies to crunching the data. We decided to do a study where we put together all of the clinical facts of each one of the 10 available trials at the time. And Dr. Niederman and I put together these different things that you can consider when using it, how to use it clinically. We know that it is definitely a good minimal invasive treatment. It definitely does not require caries removal to achieve the desired arrest rates. It is very easy to apply. It is inexpensive. It poses minimal risks to the children. in none of these clinical trials the children had any big adverse events. It is best used twice a year than once a year for caries arrest. And the beautiful thing about when you use it in your office is you don't have to place it once and walk away. But in your clinical setting, you can bring those children back to check on the arrest rates and see if it needs to be reapplied, and you can do so. In our office and in our clinic at NYU, what we do is we bring the patients back for a 2-week follow-up, and then only those lesions that don't show proper arrest, we can reapply the SDF. And then, of course, we can combine it with fluoride varnish, because some of the studies show that although SDF is better to arrest caries that are indentin, open dentinal caries, fluoride varnish still seems to be better to remineralize enamel-only lesions. So what we do is we apply SDF, and at the 3-month follow-up, we apply fluoride varnish, and we can combining it that way in a way that it can be monitored properly. And that way we can also follow up in other important things like diet counseling and plaque removal, which seems to be crucial for the success of caries arrest. Next slide, please. So SDF is very effective for caries arrest, but the staining is definitely a downside. And in a world that we live where all parents wish they could have the beautiful zirconia crowns that we have so many in the market, it is a shame that sadly, some of these children, you can only offer them a treatment that is going to give them a visible discoloration. We did a study that was published in JADA a couple of years back. And what we found out is that although parents don't like the visibility of these teeth, and there's a lot more acceptance of the treatment on back teeth than in front teeth, many parents are willing to compromise aesthetics in order to avoid more invasive scenarios for the delivery of treatment. For example, they will not want their children to have SDF if the child is cooperative for regular care. However, if their child needs to go to the OR to get the treatment, then they will say yes to the treatment. And this is up to a certain extent, because about 30 to 40% of the patients said no under any scenario. And the acceptability of the treatment was definitely modified by the degree of education of these patients and by their socioeconomic status. So it really depends a lot on the setting that you work with, on how acceptable this treatment is going to be for the parents. Next slide. So for me, SDF is a great first line of treatment because as a good desensitizer, it buys time. Some of these young children, if I do things, if I let it go for too long, they're not going to have any teeth for me to fix by the time they're 2. Some of my very sick children that I have to deal with in the OR, it may take months for them to be cleared, for them to be healthy enough for me to treat them in the OR. So for some of these patients, it just puts a stop into the progression of disease until I can do something that it is more definitive for these children. The desensitizing effect is wonderful. So many children, for example, those that have MIH and the teeth are very sensitive, they may be able to implement home measures like better brushing that will help them start bringing back or stopping the whole disease process. Next slide. How about art and ITR? Art is a traumatic restorative technique, and it is really the name for the same thing, and this is the way that they describe it in Europe. In the US, we call it interim therapeutic restoration, ITR, and they're the same thing. Maybe they are used for a different intent. One, we know that it is on a temporary basis, where the other one seems to be more of a definitive basis. But if you see at these slides that I have, perhaps we can zoom in into the left side one, this one was given to me by somebody in the audience at one of the slides that I gave. And this lovely doctor was very concerned about the fact that SDF did not seem to work on all lesions. And here you see exactly what I was describing before. Posterior lesions and large lesions are hard to arrest. And some of them, like the lower right molar, are already going into pulp blow-up, right, which will require an extraction. But this allows you to see that SDF may not be the best option in all situations, but it allows you to see where is it better. If you have a lesion that is a big open lesion, that these posterior ones, perhaps it is much, much better if they are retentive to use a glass ionomer material that will actually leave the plaque out of there and seal that lesion so it has a better chance of arrest. And with that, I'm going to mention a couple of studies. Next slide. Where you can see in this slide that there are many systematic reviews. I am mentioning this one specifically from 2018. It is a systematic review with a meta-analysis where they report that primary teeth, the success of a single surface ATR was 94% on primary teeth over 2 years, and on permanent teeth, it was 87% over 3 years. And when talking about multi-surface lesions, on primary teeth, they had a 65% over 2 years versus permanent teeth that had a 77% success over 5 years. And this is a huge difference in, it seems that it's great for one surface occlusions, and I wish my world was all about one surface, single surface occlusions where you can get great arrest rates. Once you start talking into multi-surface, 65% retention over 2 years may not really be ideal, and then we may have better options for those teeth. The second study that I like to mention is one where they compared SDF directly with glass ionomer restorations, and they found that over 2 years, both of those options had similar arrest rates. And that was very important to me because they say that you can achieve 80% arrest rates using glass ionomer, even when the glass ionomer is not retained. In that one study, Z et al. From 2012, they found that the great majority of the glass ionomer had fallen out, but the effect of the caries arrest was still present. So that is something to consider if the parents do not accept SDF because of the discoloration. You may want to try glass ionomer also just for the caries arresting effects. Next slide. So how about no caries removal? And whole technique is the best example of caries removal, of no caries removal at all. I am going to cite 3 different studies. The first one from Dr. Innes in 2018 was done in Scotland. And these children, 69% of the children that started the study were seen for a 4-year follow-up. 4 years, it's really good follow-up. And 97% of those cases were successful. What is success, right? Many of you are going to ask yourselves. So success means a major failure was anybody who came back with a defect that meant the tooth required to be extracted. That major failure required extraction. Minor failure, somebody that required some sort of pulp therapy that could be retreated, or the crown fell out and it had to be replaced. So success is all of those cases that didn't require either. There is a US retrospective study from Iowa where only 26% of the children were seen for a 20-month follow-up. So they lost a lot of the children for follow-up. However, what I want to say is that 97% of the children didn't have any problems when they placed a crown, with no caries removal at all. And to me, that is like, wow. And then there is a third study done in Sudan where it was an RCT, non-blinded, but 77% of the children that were seen at 24-month follow-up had more than 90% success when there was no caries removal. And for me, that is huge because it allows me to safely tell you that even if you hear a lot of reluctance to leave caries behind, if you are really sealing that dentin to the outside injury of having plaque constantly going in there and more bacteria that will produce more acid that will try to damage the tooth, you really have very good chances of success. For the whole technique, if the spaces are open, you can gauge the size of your crown and just let the child bite into it. If you have closed spaces, as you see in the slide, you can place an orthodontic separator to create a little bit of space, and at a later visit, you can just cement the crown. The disadvantages of a whole crown are that it raises temporarily the bite. It may have an open bite, but there are many studies that show now that that occlusion gap is only temporary and the occlusion will readjust itself within about 6 months. Next slide. So do I use whole crowns? I mean, in many of the studies, they do these studies on children that are 7 years old, 6 years old, and those are not my patient population who I have a problem with. I can do anything on a cooperative 6-year-old. I can do ideal treatment plus. My problem population are the very little guys, as I told you before. And I have used whole crowns on these children for many years already. You can see this case. Upper left is the initial visit. This child is barely 1. But this baby is being nursed at will, day and night. I can try to put SDF on those teeth, and the caries arrest is limited because I am not removing the insult. And I can try to counsel this mom until I'm blue in the face. And I know that things are not improving because those teeth are chipping away. So this child is where I decide to put a whole crown, where I don't have much worries about opening the bite. All I want is to be able to seal those teeth from the injury, so I have something to fix when that child is a little bit older. Because if in the lower left side, I have my initial slide that is from 10 years ago. I know what happens to these kids when I have nothing better to offer. And 6 extractions at 18 months it's very unacceptable to me. Next slide. So I hope that with this short talk on minimal intervention approaches, I can show you, or I can bring into the idea that they work. As we mentioned in the AAPD guideline that we published in 2016-17 for the use of SDF, none of these treatments are ideal on their own, but they should be part as a caries management plan that definitely includes behavior modification to reduce behavioral risk factors, and of course, home care. So I am not one to recommend one treatment versus another. I'm not trying to sell you one treatment, but I really believe in using our resources to do what is best for the patient in every unique clinical situation. The situation that we're living right now makes me think of an anthill in the middle of a trail that got stepped on and destroyed, right? You know what happens? The ants are pre-programmed to immediately rush back to rebuild it exactly the way it was before. But I'm asking you, are we going to do that? Or can we just are we trying to go back to practice exactly the way it was before? Or are we going to step back, give it some thought, and perhaps rebuild our hill in a better way? Next slide. And I'd like to finish by showing you this case where I did perfect dental work and I thought I was doing what I had to do, but in only 6 months when this child returned for a recall, it was already too late for that permanent molar. So I leave you with a take-home message that we should address all etiological factors with chronic disease management to give patients the best chance of achieving health, as Dr. Featherstone will discuss in his presentation. Thank you.
Regresamos con 4. Wow, that was a great presentation, Yasmi.
Thank
What
you.
do you think, Michael?
Very thorough, very comprehensive, and but I think we're going to have a lot of questions still, and I'm looking forward to the questions and answer session a little bit later.
Yes. Well, we're going to see a very short message from overalls in Mexico. Please run video. Okay, so now it's my time to introduce you, John. I don't know if you know, probably everybody in the audience know who John Featherstone is, but anyway, I'm going to read a very, very short part of your very extensive resume. Professor John Featherstone is Dean Emeritus of the School of Dentistry at the University of California, San Francisco, UCSF, and Professor Emeritus of Preventive and Restorative Dental Science at the same school. His research over the past 46 years has ranged from laboratory studies to clinical trials and the implementation of science into clinical practice. He spearheaded the development of CAMBRA, Caries Management by Risk Assessment at UCSF, and is currently active in encouraging the implementation of CAMBRA in several venues across the world. He was also a pioneer in research on laser interactions with hard tissues, and he has published over 300 papers and book chapters. And now, John, the floor is yours.
Thank you very much, Jaime. Thank you for the invitation to be part of this exciting forum. And in the very few minutes that I have to present, I'm going to give just a short introduction to managing dental caries in high-risk patients, aged 6 years through adult. Professor Crystal talked primarily about the 0 through 5 age group. Well, the disease is the same, but the management is a little different. Next slide. So you've already heard my background, so we'll move right on to the next slide. And I would like to make it very clear, I've got no personal financial interest in any company relevant to this presentation. And I'm showing several products. I don't endorse the products, and they're examples only. I'm not receiving any payment for this presentation. And I've consulted for and done research for numerous oral health companies. Next slide. So I'm going to talk to you today about minimal intervention dentistry, minimally invasive dentistry, and optimal intervention dentistry. If we can zoom in for one moment. If you look at the diagram on the left, please zoom in. Well, anyway, look at the diagram on the left. You will see that minimally invasive dentistry is a subset of minimal intervention. Thank you. And what I prefer to call what we're talking about today is optimal intervention dentistry. And it's pretty simple. We do a caries risk assessment. We do chemical therapy in the dental office and at home with the patient. And we do minimally invasive restorative dentistry to conserve tooth structure. And patient compliance is critical. And this is even more important in the COVID-19 situation and the future. The less invasive restorative dentistry we do, the better that we do is the better for several reasons. Next slide. The basis of the dental caries process is the caries balance. And we published this back in 1999. And what you'll see is that dental caries is like any other disease. It has pathological factors, which is the acid-producing bacteria, frequent eating or drinking of fermentable carbohydrates. Those are two necessary conditions. And thirdly, subnormal saliva flow. And if we have subnormal saliva flow, we have an extreme risk patient. On the right-hand side, you'll see the protective factors. Saliva to balance out subnormal saliva, fluoride, calcium, and phosphate to enhance remineralization, and something that for decades we've missed in dentistry for dealing with caries. It's a bacterial disease, so we need antibacterial therapy for high risk and extremely high risk individuals. Our job is to swing this balance to the right. Next slide. So step by step in your practice for children and adults aged 6 years upwards, you do a dental and medical history. You're doing that anyway, at least you have to be. You're going to do a clinical exam. And in that clinical exam, your aim should be to detect caries lesions early enough to reverse or prevent progression. And Dr. Crystal talked about that. Then you're going to assess the caries risk based upon items 1, 2, and 3. It's very simple to do. Then you're going to do a treatment plan, which includes chemical therapy in the office and at home. And you're going to use and prescribe fluoride and or antibacterial therapy. If you're dealing with a high risk or extremely high risk patient, you need to swing that caries balance. You need to remineralize, prevent, and deal with the bacteria. And of course, you need to use minimally invasive restorative procedures to conserve tooth structure. And then you recall and review. And a big part of the review and recall is patient compliance. So in this day and age, particularly with COVID-19 now, getting on the phone or texting patients at least every month to follow up and say, are you using your products? Do you need more products? How can we help you? Next slide. So what you see here, and if we could zoom in on this, that would be useful. So this is our recommended therapy for high risk 6-year through adult. So that's children 6 years and above and adults of any age. So we've established that they're high risk. I haven't told you how to do that, but I'm going to give you a reference as to how to do that. Any patient with active decay is at least high risk. So we're going to apply a fluoride varnish initially at that first visit and at each recall or wellness visit 4 times a year. We're going to prescribe 0.12% chlorhexidine rinse, or in some countries, it's 0.2%. Doesn't matter, one way or the other. And they're going to use it once a day, 10 milliliters, just for 1 week a month, not for the whole month. And then they do it again the next month and the next month for 1 whole week. And we have a clinical trial that shows, in fact, 2 clinical trials that shows that works. So we're reducing the bacterial challenge and we're enhancing remineralization. Also, we're going to prescribe a 5,000 part per million fluoride toothpaste. And there's 2 examples of that right here. And that's going to be used at home twice a day, every day, every month, for months. And you're going to recall 3 to 4 months for high risk and continue that therapy for at least a year. That's pretty simple. And of course, it's over to you as a clinician to decide what you're going to prescribe, what you're going to suggest. But this is our recommendation based upon our clinical trials. Next. Now for an extreme risk patient, which is high risk plus salivary dysfunction. In other words, impaired saliva, probably due to medications. The therapy is the same as I just described, and we're going to recall them 4 times a year and do a fluoride varnish, and we're going to suggest that they brush with 5,000 part per million fluoride toothpaste 3 times a day instead of just 2. And they're going to rinse with the chlorhexidine 10 mils once a day for 1 week every month. Plus a baking soda rinse. The patient can buy, or the parents can buy baking soda from the supermarket, add 2 teaspoons, that's about 5-6 grams, into 250 mils of water, shake it up, and rinse with it ad libitum daily. Next slide. So what that will do is swing the caries balance to the right and enhance the protective factors and reduce the pathological factors. It's as simple as that, ladies and gentlemen. And you will see that it does not rely on drilling and filling and placing restorations, although you have to do that, obviously, for open cavities. Next slide. So coming back to my first, or nearly first slide, this is optimal intervention dentistry, chronic disease management. We're doing caries risk assessment, chemical therapy, minimally invasive restorative treatment, and patient compliance is critical. Diet modification to reduce the frequency of carbohydrates, and home use therapeutic products. That's it. Next slide. So does the therapy really work? I don't have time to describe all the data to you, So I'm simply going to say, yes, it does work. Next slide. We started caries management by risk assessment that we called Canberra. We proposed it in 2003. That's 17 years ago. And we've used it at University of California, San Francisco since then in our pre-doctoral teaching clinics. And you'll see California Dental Association Journal in 2007 and in 2019, an update. Published all you need to know about caries risk assessment, chemical therapy, and caries management. And at the bottom, you will see two papers there, Featherstone and Shafi, Advances in Dental Research 2018, summarizing all the evidence of 20 years, almost, and Reschman et al., our second clinical trial that showed 65 to 70% reduction in dental decay over 18 months in high-risk patients. Next. So you can go to the cdafoundation.org/Canberra that you'll see at the bottom of the screen, and you can download for free the Caries Management Handbook. And that will give you all the information and much more that I've talked about today. Next slide. So ladies and gentlemen, I would like to conclude by stating that evidence-based, yes, evidence-based, optimal intervention dentistry based on caries risk assessment is the new standard of care, and it will help tremendously in the COVID-19 and any other pandemic situation. Thank you very much.
Thank you very much, John. It was a very, very nice presentation. Before we go to question and answers, we're going to have another short video from our sponsor for this third part on the Colgate Forum, Global Dentistry Challenges of the New Reality.
La línea Guard también ofrece soluciones para quien presenta problemas en las encías. El ya conocido enjuague bucal Colgate PerioGuard con clorhexidina al 0.12% ayuda a controlar el nivel de bacterias presentes en boca. Debido a su amplio espectro bactericida, reduce hasta un 99% las bacterias bucales, reduce en un 48% el sangrado gingival y hasta en un 54% la placa bacteriana. No contiene alcohol, tiene un sabor agradable a menta, fácil de utilizar y con altísimos estándares de calidad y validación científica que lo distinguen de otras clorhexidinas. Al enjuague Colgate PerioGuard se le unen dos nuevos productos que complementan y ayudan al tratamiento de las personas con problemas de encías. La nueva crema dental especializada Colgate PerioGuard con una fórmula a base de zinc que garantiza una acción antibacteriana prolongada que ayuda a prevenir la inflamación de las encías, la formación de placa y sarro dental. Ayuda a prevenir el sangrado gingival hasta en un 66.7%. Puede ser utilizada de forma diaria y prolongada, ya que su principal ingrediente activo se encuentra de forma natural en el cuerpo humano. Y por último, el nuevo cepillo dental especializado Colgate PerioGuard, de cabeza compacta, mango ergonómico antideslizante y con exclusivas cerdas cónicas Perisoft ultra suaves con puntas de filamentos microfinos, garantizan la eliminación profunda y eficiente de la placa bacteriana sin dañar las encías. Gracias a su cabeza con anatomía diamantada y componente de caucho, evita traumatismos durante el cepillado. Colgate, siempre a la vanguardia del cuidado bucal, presentó Colgate Guard, la ciencia detrás de tu sonrisa.
Okay, we're back. Michael, your first impressions on this very impressive talk.
Well, as a dentist, I feel very like I don't know enough. I mean, there's a lot of new information here that I never realized and I should have known. There's a lot of evidence out there. There's a lot of research out there that was summarized fantastically by both of our speakers here. But I have some questions, obviously, and I would like to start with Professor Featherstone. You mentioned Cambria as a risk assessment tool. Are there any other validated risk assessment tools out there that we can use as well?
Michael, thanks for the question. Yeah, Canberra is more than just a risk assessment tool. It's caries management by risk assessment. And it has a risk assessment tool in it that we've actually validated and published 4 times. There is one other validated tool in the world, and that's called Karyogram out of Sweden. And they've validated their tool a couple of times. Unfortunately, there are literally dozens, maybe hundreds of caries risk assessment tools out there in the world that are not validated. And there was a comparison done and published last December between Canberra and Karyogram and the AAPD caries risk assessment tool. Karyogram and Canberra came out looking very good. Unfortunately, the AAPD one did not.
So you mentioned here caries risk assessment and caries management tool. I presume a lot of our listeners here are very familiar with ICDAS. So how does ICDAS sort of complement or add, or how do you see it in combination? Or can you discuss how ICDAS would enter the picture here?
Yeah, that's a great question, Michael. ICDAS is a way of detecting, not diagnosing. Diagnosis is much more than that. Detecting early carious lesions and advanced carious lesions. And one uses one's eyes to do it. And the eyes are actually amazing tools to detect dental caries. And in my procedure slide, which was, I forget now, slide 10 or something, I showed to detect caries early enough to prevent progression rather than drilling and filling. So ICDAS is a fantastic tool to do exactly that. So in this day of increased PPE and reducing aerosols and whatever, the earlier we can detect, the better using ICDAS. Then we can go right into the preventive procedures, go right into everything that Dr. Crystal and I talked about. Great tool.
Okay, thank you, John. Yasmi, well, many people don't know, but we went to the same dental school.
Yes, great school.
It has the name of a company, but it doesn't have nothing to do with Unitec, which means something in English, but in Spanish means Universidad Tecnológica de México. It was probably one of the first private dental schools in Mexico. I don't want to say when.
Please don't.
But I have. There's one question here about what you put on top of silver diamine fluoride, but I want to ask you. You don't get nightmares when your operative dentistry teachers come and tell you, Yasmi, what are you doing? What happened to the copolite before you put it on program? What about destruction for prevention, extension for destruction?
It was a different world. It was a different world. And I think that the way we were taught, I think I was incredibly lucky with the kind of education that we got, but it definitely was a different world. And again, what we knew about regenerative properties of the pulp, we really, really didn't think that it could regenerate as much as it does. And then, of course, we had the limitation of the materials that we had at the time. I think the very important thing for all of us is to keep abreast of all the developments and take advantage of all the new things that we can that allow us to do things easier and better.
Yeah. So with that in mind, Jasmine, with that in mind, you mentioned you've seen tremendous amount of progress in the years you've been practicing, and Jaime and has done the same thing. So with the COVID pandemic here, John mentioned, we now have to focus much more prevention because we want to minimize aerosol generating dental procedures, so on and so forth. If you had a crystal ball, no pun intended, how would you see dentistry in another 2 years evolve based on what we're learning right now during the COVID pandemic?
Oh, I don't have a crystal ball, sadly. But what I see coming back into practice already, we opened my private practice this past week, and I hope that it is not only, we all have to work in conjunction. It is not only me believing in doing the right kind of treatments to try to prevent disease promote disease, try to maintain health, promote health, and try to keep patients healthy when I am getting paid by doing procedures. So we really think, I really think we need a system change, right? We need all of us to chip in and see the world with different eyes. If we want to live in a world where we do chronic disease management, we really, really need to be in a world where we can provide that to our patients and still be rewarded for keeping these patients healthy rather than from doing procedures. I really, really wish. I think that 2 years is a little bit too much wishful thinking. I want to be realistic here. I don't think you can completely change the world in 2 years, but we all saw what happened with the AIDS crisis around 20 years ago. It really changed completely the way we practiced. So now it is up to us to use this opportunity to try to do better, and perhaps you guys that are in more influential positions to try to change the system rather than just changing the practice. It is very, very important that we all chip in.
Yeah, no, I think you're 100% right. And I think recognizing our own fallibilities, what we do right and what we do wrong, it's probably going to help us tremendously. But this is a opportunity to do things differently in the future. And we, as you mentioned, the AIDS epidemic 35 years ago, it changed very much the things we were doing. And I hopefully we'll become better dentists after this pandemic has slowed down a little bit and become endemic rather than pandemic.
Yeah.
John, there is a question for you. Do you think that the to do rinses with baking soda is not going to alter the natural flora of the mouth, as well as if you overuse the chlorhexidine or other rinses?
Well, I could take a long time to answer this. I'll keep it very short. Let's talk about the chlorhexidine for a moment. And the chlorhexidine works in a fashion by lysing the cells, so you will never get a drug resistance building up. And if it's used as we recommend once a day for 1 week every month, staining is no longer an issue either. So that's pretty safe. Now, the baking soda, what that does is it maintains the pH much more at a neutral level. It's substituting for saliva in terms of its buffering action. And also, which we and others discovered almost 40 years ago now, and possibly others before us, that it has an antibacterial action. And that antibacterial action is particularly in two mechanisms that I don't have time to talk about, against the acid-producing bacteria. So it's not going to do any harm from that point of view. In fact, it's going to do good because it's going to alter the dysbiosis, as we call it, in the plaque.
John, can I follow up on that? A lot of people have recommended actually chlorhexidine mouth rinse as a pre-procedure rinse during the COVID pandemic. Are there any suggestion at all that chlorhexidine has antiviral or is virucidal in any kind of way? I know about the antibacterial, but does it work against viruses?
Well, I'm not familiar with the literature on that, which doesn't necessarily mean it doesn't exist. But, as a scientist, I can look at it and say the way chlorhexidine works is it's a large positive molecule that links onto the surface of the bacteria, and there's no reason why it shouldn't do the same on viruses. But I'm not aware of any strong data on that. It may be out there, but I'm not aware of it. It certainly won't do any harm, and it'll probably do good.
Yasmin, there's a question for you. Let's see if I can, I'm trying to put together a few questions. So let's say you have a molar of a first dentition, and you're going to treat it with no excavation or hardly any, and you're going to use ART, which in Mexico we call Tratamientos Restaurativos Atraumáticos, which is ART in English. And then you just put the diamine silver fluoride for how long? And then they ask us, when you do the hollow crown, which is your cement of preference to do that?
Okay, so there are many people, like if you can do art, if you can do tra, it is ideal because you are immediately sealing, so there's no plaque accumulation in that cavity. The problem is that when dealing with very young children or even with elderly adults, for example, it may be hard to do the ATR, right? And if the only thing that you can do, you don't need to do both because they both have the same rates of caries arrest. So the first line of treatment, because it's the easiest possible thing to do. If you want to paint SDF, you can have a screaming and wiggly 1-year-old, and it just requires to make things dry to be able to place that liquid into the cavity. So it's maybe your first line of treatment because it's the only thing that you can do at the time. And then you bring them back, and as soon as you can, if you can use your glass ionomer to do your art, right? Because that requires at least to keep that lesion somewhat isolated to be a little bit, to have better chances of success. And then if you see that everything is peeling off, like in that last case that I showed with my 1-year-old, then you can always have the option of doing complete coverage of that tooth with a whole crown. And you want to use a glass ionomer cement, which are, whatever you use to cement your stainless steel crowns, whatever you use to cement your orthodontic bands, which is really something that is going to have a high fluoride delivery to protect the pulp, but also keep things sealed so you don't have any further plaque accumulation in the interface with the dentin where you could end up having problems with the pulp.
Jasmine, could I continue with that one? We talked about pediatrics. What about root caries in geriatrics? Wouldn't it work the same way?
There are several clinical trials also where they have used SDF. That's not my area of expertise. I do not see elderly, but I am very familiar with the studies. Friends of mine have run them mainly in Hong Kong or from the Hong Kong group. And they have found that SDF is very effective to arrest dental decay in exposed root surfaces, so for root caries, in the elderly. And they have done these studies in many of retirement communities where people may have a lot of comorbidities that don't allow you to use local anesthetic, or in situations where patients are not very mobile and they cannot come to your office. So if they have to be treated in different settings, it is a very, very viable and good alternative. In these root surfaces, sometimes placing glass ionomer is not ideal because they may be flat exposed surface and you're worried that the glass ionomer is going to fall out immediately. But SDF seems to work very, very, very well in those surfaces. So I hope that answers.
Well, John, there are a lot of congratulations for you both on the presentations. There is a continuation of the previous question. How long can you go for the baking soda rinse? Is it you said 1 week? Is it like correct? 1 week on the month, or?
Sorry, the baking soda rinse goes on indefinitely. If you have a salivary dysfunction patient who is, for example, permanently in salivary dysfunction, like a radiation xerostomia patient, we've used baking soda on them for years. And the chlorhexidine also needs to be continued. We've had patients who've been several years on that regimen. Things slow down and the bacteria change. It's pretty interesting indeed. And that's it.
Yeah.
Jaime, and let me just continue on that one, because John there's so many things that you can do once the children are over 6. And in your stops, you have all of these amazing new products for prevention, but all of them tell you they're safe to use on patients that are 6 and older. So baking soda is one of the few extra tools that I have for my younger than 6, because number one, is a natural product. it's very, very inexpensive for the patients to use them. I cannot put my 2-year-olds on 5,000 part per million toothpaste, right? It is not what it is intended to be used for. So then on these kids, for example, on those pictures, the horror pictures that I show you, after I do the treatment, what I want is to be able to shift the microbiome of these children's mouth. And the baking soda may be one of the very few things that I have. If the mother still dilute it in the mouth and they put it in a piece of gauze, and after they clean the children's teeth, combine that with the fluoride toothpaste, because it's one of the very, very few things that I can safely use on these children to try to restore the balance of the microbiome.
Yeah. And now that we're talking about the remineralization, what is somebody asked you, John, specifically, what's your opinion on Recaldent and xylitol chewing gum?
Oh, another good question that I could spend a long time on. Recaldent showed a lot of promise, and there's clinical studies out there. It's for surface white spot lesions where there's lack of saliva flow. It's a plus. It's not dramatic, but that will help remineralizing those white spot surface lesions. Now, what was the other? Recaldent, and what was the other one?
Xylitol.
Oh, and xylitol. Wow, we all got very excited about xylitol, and the studies that came out of Finland and Sweden got us all very excited. Then a huge amount of work has been done, including some that we've done, that modified our excitement a lot. So xylitol does no harm, and it will certainly be good. And what my recommendation these days is, and summarizing the literature in 2 sentences, is that if you want to reduce the frequency of use of fermentable carbohydrates, in other words, stop people chewing on candies or whatever other carbohydrate they do numerous times a day, substitute xylitol chewing gum or xylitol mints. And that makes a huge difference in a high-risk patient. That's not enhancing remineralization, that's inhibiting the acid from dissolving the teeth numerous times a day.
Thank you. Michael, do you have another question there, or should I?
Keep going, Jaime, you're doing well.
No, you had some.
Go ahead.
You asked them already? Okay, do you know, can you recommend any brands of silver diamine fluoride? And do you know of any brands in Mexico? I think somebody's asking about the brand called Saforide.
All of those are pretty much the same. There is a brand from Argentina. There is a brand from Japan. Saforide is the old one from Japan. Elevate Oral Care is the one that we can get in the US. There are many of them. The most important thing to know about SDF is read the label, okay? Because SDF 38% concentration has shown to have better caries arresting properties than other products that have less concentrations. For example, there's a product that I'm not really sure which one is it, but there's 12% and there is 30%. And there is a huge difference in the clinical trials when they compare directly 12 or 30% versus 38%. So it is important to know the concentration. That's one thing. And then, of course, when it comes to mechanism of action of SDF, the silver seems to have antibacterial properties. Of course, the fluoride, which is in very high concentrations, twice as much as fluoride varnish, remineralizes the dentin and the rest of the tooth. But all of these is set stable by ammonia solution, which is bound. It's not free ammonia, it is bound, but it keeps the solution stable. But it also seems to have a synergistic effect that creates unfavorable conditions for enzymes that help destroy dentin to work. That means like we ran a study that was published in JADA last year, I think, right, Michael? And then we saw that the pH of SDF that is manufactured in the US was 10. And that pH seems to be important. One of the minor side effects of SDF is that it can create gingival irritation. I know there are products out there that have a much higher pH. They are not intended to be used for caries arrest on teeth. There is a specific product that has a much higher pH that is supposed to be used with rubber dam just on the surface of the tooth to disinfect and seal, desensitize, and then you put your restorative material. But when the pH is 13 or higher, it's not ideal. It is not intended to be put near the gingiva when you're not isolating the tooth.
Just on the continuation on SDF, if the child moves and by an accident, they get a tattoo from the SDF in the cheek or in the hand, is there a treatment for that, or is it a tattoo for life?
Well, we all know it depends on where it is, and skin and epithelium especially is shed. It grows very fast. It is shed very fast. In the surface of the skin, it takes a little bit longer, but that is not going to go into the deeper layers of the dermis, creating a permanent tattoo. It's definitely going to go away and be shed out, but it's quite embarrassing for it to happen on your watch. So we like to be very, very careful. We try to isolate as much as we can. We try to put in the skin, not in the mucosa, but in the skin, we try to put some petroleum jelly or chapstick or something to be able to protect those children not to get that. And then, of course, there are some sodium, some other things that you can use to try to remove the stain. But the best thing is to try to be careful not to have the stain.
Jasmine, I have a difficult question for you.
Sure. Right in.
Caries in kids is the most common chronic disease in the world.
Yep, sadly.
Should we involve pediatricians to do varnish, to do fluoride varnish and some type of procedure when apparently either we don't have enough people, or we don't do what we're supposed to do, or we don't see the children? Should we involve physicians actually in helping to prevent caries in kids?
That's a great, great question. Of course we should. I have been very actively involved working with the American Academy of Pediatrics, trying to raise this issue. In my practice, I am on staff at two different hospitals, at Robert Wood Johnson and also at Somerset Hospital near my town. They have a family practice MD residency, and every single one of the residents has a rotation in my practice. Does it matter? Of course it matters. It is not only pediatricians, but family practice MDs are going to be the very first people to see these children. And what I think in my setting, they get paid to do fluoride varnish, and I get paid to do fluoride varnish. And of course, what is possibly the best thing that this child can have to keep them healthy than to have all of us promoting the same thing? We all have to be consistent, giving the same advance. And you saw that. They may see the child 6 times before that child is 3. And sometimes I don't get a chance to see the child until they're 3, and unfortunately it is too late. So yes, I encourage everybody to engage their family practice MDs or their pediatricians to work together, because we should be a team for health.
So we shouldn't have a medical home, a dental home, we should have a health home.
And it should be something that we don't have to feel territorial for, because they need us in many ways. And I'm saying pediatricians, family doctors, they need us in many ways like we need them. We are part of the same team. We're all rooting for the same goal, right?
Could I add to that? It's in the ideal world, we should have pediatricians, family practice physicians, all doing a simple form of caries risk assessment. I could teach them to do it in an hour. And that should be part of the insurance program, and not just fluoride varnish. It's much more than that, because putting fluoride varnish on twice a year does not deal with high-risk children. It helps with high-risk adults, but it doesn't deal with it. So we need somehow to make that huge breakthrough with the medical profession. And maybe COVID-19 is going to help us do that. I sure hope it does. It's been a dream of mine for several decades to get this going, and a few others as well.
And they have, in all fairness, the AAP has been very active. About more than 15 years ago, we worked on a team that developed a caries risk assessment form that could be used in less than 2 minutes. Our pediatricians are so busy, and they have so many, a checklist of 20, 30 things that have to be checked within their well-home visits. And we worked together on developing that, and it is on their Bright Futures website.
John, can I just have one question for John here, Jaime?
Okay.
I'm not a cardiologist. I'm in oral medicine. Is there any tool or any test that I can actually use to measure caries progression?
Yes, it's called using either ICDAS or X-rays over time.
But they will actually tell me progression, or they will tell me I reached the next step?
It'll tell you that the lesion has progressed and
Right.
you've reached the next step.
But what I want to know is, I see a lesion, can I determine how fast that lesion will progress or not? Is there any measurement? Is there any tool that I can use? Bacterial load, caries risk assessment, obviously, diet, etc., etc. Is there anything there? Because I, as a dentist, I see a lesion, and my question is, okay, I can wait until you go to the next step, and I know it progressed, or I can say, wait a second, I have lesion A here. I need to tell the patients you have a 60% chance it's going to get so much worse in the next 6 months.
Right. So come back to your observation or clinical observation or observation with some electronic gadgetry and whatever. People have been working on this for decades. And the bottom line is people have come up with observations that say it's an active lesion or an inactive lesion. I'm sorry to say that the data is not really supporting that.
Okay.
What is supported? We can do a risk assessment, and we can determine the likelihood of somebody getting new decay in the coming months or years. And that's as good as we can do, which is pretty darn good, because that tells us how to intervene and how to bring that risk down from high to low within months. And I'm actually working with an insurance company that's incentivizing their practitioners to do exactly that. And it looks like it's going to work.
Okay. There's a question. This is going to be the last question because we're already going to reach 90 minutes. It's incredible how time flies. There are fluoride varnish, either you or both of you. There are fluoride varnishes that mix 6% of calcium fluoride plus 6% of sodium fluoride, and they seem to work better when there is already a cavitation in the tooth. What's your opinion?
Sorry,
I leave you to answer that, John.
Yeah. Sorry, could you say that?
It says there are some mixed fluoride varnish that have 6% of calcium fluoride plus 6% of sodium fluoride. And they seem to be better to arrest caries when there is already a cavity in the tooth.
Well, I would like to see the clinical data that supports that seems to be better statement. And just looking at it from a fundamental point of view, calcium fluoride is largely insoluble. It dissolves over a period of months. So it's good and bad. And one of the biggest failures in the world of fluoride toothpaste was when a company that shall remain nameless put calcium fluoride in their toothpaste, and it failed to work totally because the fluoride was not available. Now, on the other hand, if you use a 5,000 part per million fluoride toothpaste and put that into the mouth, it actually precipitates calcium fluoride in the plaque, which dissolves over a period of time. So the bottom line is, I would stick with the clinically proven sodium fluoride varnish until we've got convincing proof otherwise.
Or the 5,000 part per million product that I absolutely rely on. We have a pedo ortho practice, so we have a lot of kids that are high risk, and you want it there when you need it.
And one of the things...
Before we say, yeah?
Just say one thing here, coming back to Michael's question about root caries. There are two studies on root caries showing that 5,000 part per million toothpaste is an extremely effective root caries prevention and treatment tool. And secondly, I would be remiss in not making a statement that there's a wonderful study showing that, in fact, more than one, showing that brushing twice a day with a fluoride toothpaste will give you reductions of between 50 and 60% compared with saying you brush once a day. So add that to the 5,000 part per million fluoride for the high-risk individuals. And we and others have shown that that frequency of brushing is very important. It's like any medicine. Having it sit in your medicine cabinet, it doesn't work. And if you use it 2 or 3 times a day, then it makes a huge difference, just that alone.
And the wonderful thing that has changed, Jaime, for example, you were mentioning of changes, is many of those products are now available worldwide, OTC, over the counter. Yes. So that is a huge improvement. Whenever we get invited to present a lecture, we always find out which are the available products. And I think that is a great, great step forward, that in many countries that didn't have them available, or that they were available only with a prescription, now patients can get them. That's amazing.
I mean, I'm going to speak in one more. You have to excuse me, but I have to ask this question. So, John, so fluoride varnish mouth rinses should also be recommended for geriatric patients?
Simple answer is yes. And for geriatric patients, prevention is better than cure, particularly with root caries. You know, amalgams are not satisfactory. Glass ionomus are okay. If it's very easy to prevent root caries simply by brushing twice a day with a fluoride toothpaste. And assessing the risk. If the patient's at high risk, you add the chlorhexidine or whatever. It's pretty straightforward, and it'll make a huge difference in the geriatric population.
Okay, we're going to go to a short video, and we're going to come back so to close the program. So please, can you run the video, please?
Si te lavas bien las manos, lograrás prevenir con jabón y un buen tallado tu salud hoy queda en ti. Cepillarte bien los dientes te protege. Cepillar y lavar es la respuesta. Cepillar hasta llegar a todos los rincones de tu cavidad bucal.
This is just a TikTok campaign that we are launching from the Mexican Dental Association Foundation. That yes, it was a time because quarantine is almost over in many places, or the first stage at least. And it's very important to wash your hands, but don't forget to brush your teeth as well. And ahora vamos a now we're gonna go to 2 last videos to close this 3-part Colgate forum that was really amazing. Right, Michael?
I loved it. Thank you for inviting me, Jaime. It's been my honor to be here with you.
Vamos, pues.
Buenas tardes, colegas. Soy Julio Bermejo y represento a Colgate México. Quiero agradecerles el habernos acompañado en este ciclo de foros que les hemos traído a ustedes con información relevante sobre los retos que enfrenta la odontología ante una nueva realidad mundial, contando con la participación de panelistas de primer nivel. Nuevamente un agradecimiento al Dr. Edelson por coordinarlo y a la Asociación Dental Mexicana por hacerlo realidad. Esperamos encontrarnos pronto a través del programa de educación continua de la ADM que apoyamos permanentemente. Muchas gracias.
Buenas tardes, soy Manuel Sergio Martínez Martínez, presidente de la Asociación Dental Mexicana, Federación Nacional de Colegios de Cirujanos Dentistas, AC. Me complace gratamente continuar presenciando el surgimiento de proyectos en beneficio de todo nuestro gremio odontológico, en los cuales, como ha sido el caso de este espacio de Genie in a Bottle, se ofrecen temas de actualidad y en donde además se presentan invitados internacionales cuya experiencia nos enriquece a todos. Hoy que concluye este innovador foro Colgate, no me queda más que reconocer y felicitar a todas las personas que participaron en la logística y realización de estos 3 programas. Desde luego, muy especialmente a sus conductores, al Dr. Jaime Edelson Tishman y al Dr. Michael Glick, por su esfuerzo y compromiso con la odontología. A todos los socios ADM que estuvieron presentes durante estas interesantes transmisiones, los invito a que sigan capacitándose e informándose para afrontar con preparación y profesionalismo los cambios y retos que se nos presentan hoy en día. A todos les mando un fuerte abrazo desde casa y nuevamente enhorabuena por el exitoso cierre de Genie in a Bottle. Espero nos sigan y nos encontremos en próximos proyectos. Muchas gracias.
Okay, yes, well, this is the end of the Colgate forum, but I want to invite all of you on the 9th of June. We're going to move. It's not going to be on Fridays anymore. It's not going to be in the midday anymore because many dentists are already getting their hands wet in their offices. So the program will continue in a night fashion on Tuesday, June the 9th at 21 hours Mexico City time. And the programs are going to be, that program is going to be in Spanish. We already have the deans of the UABC Tijuana, of the UNAM National University Dental School, and the Anáhuac Mayab in Mérida, which, and together we will debate these important things of, okay, now it's safe to go to the clinics, but it's a big challenge to go back to public dentistry, and we also going to have something about it. And it's a huge challenge to go back to dental schools, and so the students can go back to their clinical part. We're going to have that program on June the 9th. It's going to be in Spanish. We didn't need a translation in YouTube for English-speaking people. And the following week, with the help of Michael, we're going to get 3 very distinguished deans of dental schools in the United States to discuss and debate actually the same things. We also want to tell you that we put both Yasmi and John were very nice, and they sent some materials that you can unload in both either ID Academia or the Mexican Dental Association webpage. And we also want to, Michael, would you like to talk a little bit about your latest book?
Yes, so together with the Evidence-Based Center at the American Dental Association, we have actually published a book called How to Use Evidence-Based Dental Practice to Improve Your Clinical Decision-Making. Let me just mention that I don't get any any royalties for selling this book or anything like it, but it's an excellent book if you want to start to actually practice evidence-based dentistry. It will give you all the tools that you need in order to start you off on an evidence-based path. So we have 5 editors. It was started by Alonso Carrasco Labra, who is the head of the Evidence-Based Center at ADA, and it's produced by the American Dental Association.
Okay, so well, believe it or not, we've been 90 minutes live from all the way in San Francisco. John, thank you very much. Yasmi in New York.
Thank you.
As well as Michael in New York. I think we have to learn how to do high five in this system. We thank you all for being here. And please join us again on the Wednesday of next week. We're gonna present the Mexican platform for dentists on how to learn how to keep themselves safe, to keep their patients safe. There's going to be a lot of information for dentists, for the public. And there's going to be materials so dentists can download and send to their patients, telling them all the measures we have to take in dentistry to keep them safe. Thank you very much. It's been a pleasure to be with you. And we also want to thank our translator. You don't see her, but she's there in the Facebook Live. Thank you, Samantha, for excellent work during these past 3 weeks in this new exercise of trying to communicate dentistry in a different way. Thank you all, wherever you are in the world. Michael,
Thank you.
It's a pleasure. See you in 2 programs.
Thank you very much. Take care, everyone. Stay safe and make smart decisions.
Okay.